The ankle, chronic or overuse injuries. When a patient continues to suffer ankle sprains, they run into an issue of chronic ankle instability. Chronic ankle instability develops following one-third of all acute ankle sprains. Patients can suffer from mechanical or functional instabilities. A mechanical instability is laxity that physically allows for movement beyond the physiologic limit of the ankle's range of motion. A functional instability is a subjective feeling that the ankle is unstable. These are attributed to proprioceptive and or neuromuscular deficits that negatively impact postural control and thus ankle stability and balance. Patients and clinicians should focus on a combination of ankle strengthening and improving proprioception to address these issues. Achilles tendinopathy or strain. An Achilles tendon rupture is when the Achilles tendon breaks. The Achilles is the most commonly injured tendon in the body. A rupture can occur while performing actions requiring explosive acceleration, such as pushing off or jumping. The male to female ratio for Achilles tendon rupture varies between 7 to 1 and 4 to 1 across various studies. The Achilles tendon is most commonly injured by sudden plantar flexion or dorsiflexion of the ankle, or by forced dorsiflexion of the ankle outside of its normal range of motion. Other mechanisms by which the Achilles tendon can be torn involve sudden direct trauma to the tendon, or sudden activation of the Achilles tendon after atrophy from prolonged periods of inactivity. Some other common tears can occur from overuse while participating in intense sport. Twisting or jerking motions can also contribute to injury. Fluoroquinoline antibiotics, the most common of which is ciprofloxacin, are known to increase the risk of tendon rupture, particularly at the Achilles tendon. Signs and symptoms of an Achilles tendon rupture include the history of a tendinopathy, which will result in pain with active plantar flexion. This pain is typically worse in the morning or at the beginning of activity. When the Achilles tendon does rupture, it is not uncommon for it to be heard across the field or court. Many people describe this feeling as being kicked, hit, or even shot in the back of the leg. The sound itself sounds like a shotgun blast. The person will have trouble completing plantar flexion activity and maybe even difficulty standing. Other things you might notice when examining someone for an Achilles tendon rupture is a history of tendinopathy exostosis, or what is commonly called pump bump, which is a bony outgrowth on the heel. The Achilles tendon has pulled away from the calcaneus and an exostosis is formed. The individual might also report a squeaky sensation that was heard or felt in the calf before the injury, and may have had previous history of calf tightness. When there is a rupture, there is most often a deformity that is obvious, and the calf will contract with the torn Achilles tendon. Treatment typically includes surgical intervention to reattach the torn Achilles tendon. Achilles tendon management. For tendonitis, rest, stretching, strengthening, cryotherapy, and NSAIDs are recommended. For an Achilles tendon rupture, immediate referral to a physician's office is recommended, particularly an orthopedic surgeon. Many times, individuals will go to an emergency department to help with pain management, and surgical intervention to reattach the torn Achilles tendon is almost always recommended. Medial tibial stress syndrome. Shin splints or medial tibial stress syndrome are a common exercise-related problem. The term shin splints refers to pain along the inner edge of the shin bone or the tibia. Shin splints or medial tibial stress syndrome is an inflammation of the muscles, tendons, and bone tissue around the tibia. Pain typically occurs along the inner border of the tibia, where the muscles attach to the bone. Shin splints typically develop after physical activity. In general, the shin splints will develop when the muscle and the bone tissue, also known as the periosteum, in the leg become overworked by repetitive activity. Shin splints often occur after sudden changes in physical activity. These changes can be in frequency, such as increasing the number of days you exercise each week. Changes in duration and intensity, such as running longer distances or on hills, can also cause shin splints. Other possible causes of medial tibial stress syndrome include stress fracture, periostitis, tibialis posterior, and or tibialis anterior overuse. Other factors that contribute to shin splints include having flat feet or abnormally rigid arches, exercising with improper or worn out footwear, and exercising with improper or worn out footwear. Almost all patients who suffer from medial tibial stress syndrome have a foot alignment or biomechanical issue with their gait. Runners are at the highest risk for developing shin splints. Dancers and military recruits are two other groups that are frequently diagnosed with this condition as well. Any vigorous sport activity can bring on shin splints, especially if an individual is just starting a fitness program. The most common sign or symptom for shin splints is pain along the border of the tibia. Mild swelling in the area may also occur. Shin splints may occur as the result of a stress fracture. Shin splints or stress fracture pain may be sharp and razor-like or dull and throbbing, with the pain occurring both during and after exercise. The pain may be aggravated by touching the sore spot, and the person may also have crepitus, which is a crunching with palpation. If a stress fracture is present, the person may complain of pain that wakes them up at night. An X-ray may be negative since stress fractures take a while to show up and usually show up when they're healing. Therefore, a bone scan may be a better evaluative tool. Simple measures can relieve the pain of shin splints. Rest, ice, and stretching of the gastrocsoleus complex often help. Taking care not to overdo an exercise routine will help prevent shin splints or medial tibial stress syndrome from coming back. A stress fracture. This is often seen in running and jumping activities. The most common sites for stress fractures in the lower extremity are the second metatarsal, under the sesamoid bones, the navicular, the calcaneus, and the tibia and the fibula. Signs and symptoms of stress fractures. The pain begins insidiously, which means we cannot pinpoint a direct date or time of the injury. This pain increases with activity and typically decreases with rest. Pain is usually limited to the fracture site. There is pain with percussion, meaning if we bump the area or use a tuning fork or ultrasound, which causes vibration, it will result in pain for the patient. To manage this condition, we follow the standard acute care protocol. If the individual is not improving within a few weeks, then a physician referral is warranted. Deep vein thrombosis, or DVT. A deep vein thrombosis, or DVT, occurs when a blood clot or thrombus forms in one or more of the deep veins in the body, usually in the legs. A deep vein thrombosis can cause leg pain or swelling, but may occur without any symptoms. A deep vein thrombosis can also happen if you do not move your leg for long periods of time, such as after surgery, following an accident, or when you are confined to a hospital or nursing home bed, or even flying on an airplane. The signs and symptoms of deep vein thrombosis can include asymptomatic at first, and an individual may not have any symptoms appear at all. If they do have symptoms, most often they will complain of a dull, achy pain in one leg. The pain often starts in the calf, and it can feel like cramping or soreness. This pain progresses to intense, throbbing pain. Fatigue and cramps are common. The individual will likely have warm skin, swelling, and redness. Tightness of the calf muscle is common, and we see swelling in the affected leg. Rarely, there may be swelling in both legs. A deep vein thrombosis is a serious condition because blood clots in the veins can break loose and travel through the bloodstream and lodge in the lungs, heart, or brain, blocking blood flow. A blood clot that goes to the lungs would result in a pulmonary embolism. A clot that goes to the heart could result in a heart attack or a myocardial infarction, and a clot that goes to the brain could result in a stroke. Therefore, immediate referral is the recommended management for a person suspected of having a deep vein thrombosis. Seaver's disease, also known as calcaneal apophysitis. This is associated with growth spurts, tight heel cords, poor hamstring flexibility, and other biomechanical abnormalities contributing to poor shock absorption in the lower extremity. Because the apophyseal plate is vertically oriented in the heel, it is particularly susceptible to shearing stresses from the gastrocnemius muscle. Signs and symptoms include unilateral or bilateral, intermittent or continuous posterior heel pain that occurs with activity shortly after beginning a new sport or season. Gait may or may not be normal, but especially in children, they may walk with a limp or exhibit a forceful heel strike. Point tenderness is typically found around the insertion of the Achilles tendon along the posterior border of the calcaneus. There is typically pain with medial lateral compression of the calcaneus. Most commonly, patients will complain of pain while standing on their tippy toes. This is a condition known as Seaver's sign. Heel cord flexibility is tested by passively dorsiflexing the individual's foot with the knee extended. There is typically a reduction in the range of motion by at least 10 degrees, and testing may elicit an increase in the individual's pain. This condition usually resolves itself with closure of the apophysis as the individual grows. Standard management is rest, standard acute care, and if the individual is not improving, then physician referral.